Welcome, everyone, to Mayo Clinic Q&A. I'm Dr. Tom Shives.
And I'm Tracy McCrae.
Heart disease. It's still the #1 killer of women in this country. In fact, ever since 1984, more women have died of heart disease than men.
Amazing.
Today on Mayo Clinic Radio, we'll talk with a women's health expert, Dr. Rekha Mankad. We'll find out if women have become more aware of their risk for heart disease in the past few years.
We're going to talk about how the symptoms of heart disease are different in women than men and get her advice on how women can lead heart-healthy lives. Plus, we'll learn about the increased risk of heart disease and stroke for patients with rheumatoid arthritis and other autoimmune diseases. Welcome back to the program, Dr. Rekha Mankad.
Thank you very much. It's a pleasure to be here.
So, Dr. Mankad, are we doing better? Are more women recognizing the fact that heart disease is the disease that's most likely to kill them?
Yes, we are actually doing better. And in the last few years, the mortality rates for women with heart disease have dropped quite a bit. So actually, the number of women dying of heart disease compared to men dying of heart disease is actually pretty equal now.
Okay, so I was wrong. Aren't you women glad to hear that?
Well, I mean, when you look at that figure, that 1984, that's a long time that women went basically not even considering that they could have heart disease or die of heart attack. That is still impressive to me.
And it's true. And we have to remember that although I say that the numbers are equal as far as the number of people dying, we have to remember that heart disease is still less prevalent in women. So it still is more prevalent in men, meaning that it's more likely that a man is going to have heart disease. So when you look at the number of deaths, it still is important to recognize that in a disease that's less prevalent in women, we have equal numbers of deaths. So it is very important to recognize. But yeah, there was a period of time where no woman had any idea that the thing she was going to die of was actually heart disease.
She was more worried about breast cancer.
Absolutely.
Okay. So why is it that heart disease is more prevalent in men? I know there is some protective hormonal effect and up until menopause, and then things start to equal out, don't they?
That's exactly true. So in younger women, so those who are premenopausal, the likelihood of having traditional coronary artery disease or plaque building up in the arteries.
The arteries that supply the heart muscle.
You're right. That's less common. And you're right. Estrogen actually protects women from having that process develop. But as soon as a woman reaches her mid-50s, the occurrence of heart disease sort of skyrockets and essentially it equals that of men within sort of 5 years after menopause.
But there are also some barriers to women receiving excellent care for heart disease, aren't there?
Yeah, I think there still is this gap of knowledge of the recognition of heart disease being an important risk factor for women's symptoms and signs. So I think there's always that delay in diagnosis that we see, especially in younger women. I think both providers and patients continue to say, well, yes, I understand that heart disease is the #1 killer of women, but that's not going to happen to me personally. Sure. So individually, they don't recognize the risk, even though they might know the statistics.
Recent article, and I read this, and I have the quote here, sort of amazing to me. Studies show women having heart attacks wait more than 30% longer than men to go to the ER and experience a 20% longer wait time than men. True?
Yeah, that's what we see. I mean, I think, again, it's very dependent on where you go and how experienced a center might be dealing with, women and heart disease. But yeah, I think certainly the wait time for women continue to think it's something else before they'll call an ambulance or ask to be taken in. And that sort of segues into the fact that the symptoms are a little bit less classic for women. So they think it's their stomach or something they ate, something other than heart disease is what sort of drives them. And usually it's only after they talk to someone or they realize the symptoms aren't going away that they go, I better go get checked out.
But they make their husband go right away.
Well, that's because men in general have the crushing, weight on the chest type thing.
Elephant sitting on the chest.
Yeah, and for women, it's, I feel like I'm going to throw up, or I just feel clammy and gross. I don't really quite feel right. I mean, that can cover a whole lot of experiences. Food poisoning.
Yeah. They're nonspecific symptoms, but we have to recognize that chest pain is actually one of the symptoms. It's a fairly common symptom, but it's not the predominant or only symptom. And it usually is not as severe, and it's associated with shortness of breath, nausea, a feeling of unease. The pain may be in the back or limited to the shoulders. So it is different, and I think that's why there is this a delay or maybe even confusion that develops, like, is this really my heart? Should it be, should I get it checked out or not?
Fatigue, shortness of breath are the two most common symptoms of a heart attack in women?
Well, they're not they are highly prevalent. They're not the most common. Chest pain is still the most common symptom, but it is sort of in with all these other symptoms. So it's not the only symptom.
All right. Are there unusual kinds of heart attacks in women that that the women in this audience ought to be concerned about, ought to know about?
Yeah. So there is a condition called spontaneous coronary artery dissection. So it's a heart attack that happens in young women. So these are typically the premenopausal women, although the range can be fairly broad as far as ages. And this is a woman who doesn't have the regular risk factors for that plaque that builds up in heart arteries. And what this condition is a tear of the heart artery. So it decreases blood flow just like a regular heart attack does, but the reasons for it isn't due to a plaque that's rupturing. It's a tear in the artery. And that, again, happens in very young women. It can happen in 20 and 30-year-old women. So clearly not something that they are recognizing that could happen to them.
Is chest pain the most common symptom?
Chest pain is the most common symptom.
We have any idea why this happens?
We know that there's a link between this condition and another condition called fibromuscular dysplasia. So both of these conditions show that the vessel wall is friable, or at least it's something about that vessel wall is abnormal. Huh? Yeah, it's fragile. We don't know why. These tend to happen, these events happen during periods of extreme emotion or physical activity. So we've had women who had just gone out for a run, a really long run, or in a very heated argument, and they can have these episodes. And again, when a 20 or 30-year-old is going into the hospital with chest pain, the last thing most people are thinking of is that it's a heart attack.
But I assume if you get there in time, it's fixable?
Yeah, it's very different than a regular heart attack because this tear in the artery can actually heal itself. So first of all, you have to have a high index of suspicion to know that this might be the reason that that patient's having the heart attack. So you do an angiogram like you would for any other heart attack.
That's the dye test where you can actually see the tear in the artery.
Correct. But again, you have to have a high index of suspicion because if the artery is torn but things look good, it might be better not to do anything to that artery like a stent procedure.
What about all of the other things that you're supposed to do for good heart health?
Yeah, let's talk about prevention.
Yeah.
Yes.
Because if you told me what my heart numbers were, if I could remember them, that would be another thing. But how important is it to know what your numbers are and to know your cholesterol and those different things?
Yeah, it's really important. I think everybody needs to take ownership of their own health. So understanding what high blood pressure is or normal blood pressure, I think, is very important. Now, high blood pressure doesn't give you a symptom. So you'll only know if that's abnormal if you go in and get regular checkups to see if your blood pressure is elevated. Cholesterol numbers should be checked in your young adulthood and then repeated at certain intervals after that. So those are really important things to be able to have checked and to be able to follow to see how your risk changes over your lifetime.
What do you think about the new blood pressure guidelines? Aren't they a little bit strict, 120 over 80 or less? I mean, there are not that many people who are in that range, are there?
There are people that are in that range, and it sounds strict, but if you look at the data, I mean, that's where the benefit is to have those lower numbers. As soon as that number, the top number, gets above 120, you start increasing your risk of heart attack and stroke. And we had thought, well, maybe we don't need to be that stringent, but the most recent documents and the guidelines have suggested that if you really want to be in optimal health, that blood pressure be less than 120 over 80.
Now, before I went to medical school, my mom always told me that the systolic number, she had high blood pressure, that her doctor explained to her that as long as it was 120 plus your age, you were okay. Yeah, I mean, that was a while ago, but that's what we used to think, right. And we've learned a great deal since then.
Quite a bit, and we have to be careful because as you get older, your blood pressure, I mean, it's much more common to have high blood pressure as we all get older. But even in the elderly, being stricter with blood pressure does have benefit.
All right, so blood pressure is important. Obviously, smoking is the first thing that women and men ought to do to protect their heart health.
Absolutely.
Okay, what about cholesterol? Is that as important as we have thought?
Yeah, it is important, and it remains something that we as cardiologists follow very closely. I think we do know it's more complex than the number by itself, so you have to take that into context with other risk factors. We know people can have high cholesterol and never have a cardiac event, and it's because of the makeup of that cholesterol is just healthier for that person. So, as an isolated number, you have to be careful, but you take it in context with other risk factors as well. But certain people who have really high bad cholesterol, that's the LDL cholesterol, if it's really high, they could have a condition called familial hypercholesterolemia. Those people are at very high risk for cardiovascular or cerebrovascular events.
But drugs work to lower that.
Yes, they do.
And we know that you should lose weight and get active. What about sleep? Is sleep important for heart health?
Sleep is very important for heart health because that's when we sort of reset. That's when we rejuvenate. So if we don't get enough sleep, and that does vary by person, every person's a little bit different, but we're looking at somewhere to 6 to 8 hours of sleep at night, and that's restful sleep. It really is a benefit for your heart health.
All right, what's your favorite diet for heart health?
So the Mediterranean diet is a really good diet and one that I think is achievable. But I will tell you that the recent literature is really sort of going towards a purely plant-based diet.
Yeah. I knew that she was going to say that.
Yes, tell us about the Mediterranean diet. What's the difference between a plant-based diet and the Mediterranean diet?
So the Mediterranean diet allows for fish. So that's the big difference. I mean, the plant-based diet, it's no animal proteins at all.
Chickens?
In
chicken?
the plant-based, it's all plant.
But the Mediterranean chicken?
Well, I mean, it's not that you can't have it, but they tell you that where you should strive to get your protein is in fish or in legumes. So, lentils and things like that is the best place to get your protein source.
All right, and get active. Exercise is really important. It can certainly reduce your risk of heart disease.
Yeah, exercise is very important.
Anything else we missed?
Diabetes is another risk
your
factor for heart
sugar.
disease. So
huge risk
right.
factors. Is it true that half of the people, 50% or more of the people who go into the emergency room with a heart attack have diabetes? Or
I'm not sure it's quite that high, but
it's
quite high. And it might not be full-blown diabetes, but it might be early diabetes or glucose intolerance, we would say, where the blood sugar is elevated but not in the criteria of diabetes. And that's important, and that goes along with a condition called metabolic syndrome, where you have an elevated blood pressure, some bad cholesterol numbers, and elevated blood sugar, and carry that fat in your middle, the spare tire, we say.
All right, so you got to know your blood pressure. You got to know your cholesterol. Keep your weight down. Did I miss anything?
Exercise.
Yep. And don't smoke. Yeah, that's probably the most important one. Women's heart health expert, Dr. Rekha Mankad. Heart disease is still the #1 killer of women in America, taking the lives of 500,000 women a year, isn't it?
That's correct.
But the word is getting out. Apparently more women are aware of the fact that heart disease is not just a disease of men. It's still also the #1 killer of women. And you know what we've got coming up? We're going to find out about an increased risk for cardiovascular disease in people with rheumatoid arthritis or an other autoimmune disease. Welcome back to Mayo Clinic Q&A. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Now, in addition to being a women's heart health expert, Dr. Rekha Mankad is also director of the Cardio-Rheumatology Clinic at the Mayo Clinic in Rochester. Even I didn't know there was such a thing.
Well, we did an interview, a cardio-oncologist, so cancer and our heart. So what about rheumatology and our heart? What's the link?
So I'll sort of give you some historical details first. Actually, this has been identified in the rheumatology literature for decades, where patients with specifically rheumatoid arthritis and lupus were noted to have more heart disease risk than patients without those conditions. So that had been reported in epidemiologic studies for years, but nobody had really talked about it. So I actually just accidentally happened upon this when I was sent a patient by one of the rheumatologists, and I thought, why are they sending me a patient with rheumatoid arthritis to assess their heart? And then I started looking at the literature and I thought, wow, there is a link. and started looking into this deeper. And what we know is that the process of plaque building up in the heart arteries, or atherosclerosis, yes, it's about cholesterol, blood pressure, and all of those things, but there's also a link to inflammation. And we see that that process of plaque building up in the arteries, actually inflammation can get that plaque to get started and to progress. And this is why, just as cardiologists, we do check inflammatory markers frequently when we're evaluating somebody's heart disease risk, and that blood test is called a C-reactive protein. So patients with rheumatoid arthritis, lupus, and many of the others, those are all inflammatory autoimmune conditions. So it makes sense why these patients have increased risk of heart disease. They have a constant elevated level of inflammation. It might be all the time, or it might just happen in flares. And there's been a lot of studies done looking at the link between these conditions.
Well, when I first heard it, it makes sense to me that if you've got lupus or fibromyalgia or arthritis, that you're not as active as you could be or should be. Mm-hmm. And so that would be the reason why you have heart disease, but that's not it. It just,
no.
I would imagine it contributes, though.
Yes, it does. And that's a very important contribution, because patients with those conditions do tend to be less physically active, and therefore they sort of augment their risk. So they already have the risk related to their condition by itself, and then that risk can be further enhanced because they're less active. By being less active, they may be more overweight. By being more overweight and less active, their blood pressure may be higher and their cholesterol may be more abnormal. So all of those do tie in. But the disease itself has an independent risk.
Remind our audience again what we mean when we talk about an autoimmune disease.
So these are diseases where your own body sort of is destroying tissue. So there is antibodies that for some reason develop and destroys tissue. For rheumatoid arthritis, the symptoms are typically in the joints. So most of the symptoms are in the joints, and that's where the inflammation is sort of visibly, we see it attacking. But that inflammation is seen throughout the body, and that's why the heart is affected. And in lupus, multiple organs can be involved in that condition as well. So in all of these rheumatologic conditions, there's psoriatic arthritis, there's systemic sclerosis, there's many of them, and they've all been looked at, and they all appear to have this increased risk for heart disease.
So what should patients, and I'm sure you counsel them on this, if they've got some sort of disease, that whole spectrum of rheumatologic diseases, what can they do to prevent heart disease?
Well, I think the first thing is education. So they need to understand that this risk exists, and they should talk with their physicians about ways to become more heart healthy. I do see a lot of patients with these conditions, and one of the mainstays that I do is discuss the link between the diseases, and then we look at the things we can fix. So we look at the cholesterol, we look at the blood pressure, we talk about ways to get more aerobically fit and healthier in general with diet and exercise. And then we talk about ways that the actual disease can also be modified. So if the disease isn't under control and they have more inflammation, I need to talk to my rheumatology colleagues about how to get that inflammation under better control. So the combination of things needs to take place to decrease their risk.
Do they need to be screened periodically, patients with rheumatologic diseases?
Well, so we don't have any guidelines, I'll tell you that, although the most recent guidelines for the prevention of heart disease did include rheumatologic autoimmune inflammatory conditions as an at-risk group. And it's called a risk enhancer. So if you have one of those conditions, you sort of look at the big picture with that patient and say, well, their risk is going to be higher by having that condition. But we don't really know, should we be evaluating them every couple of years or every 5 years? We don't know. What I typically do is when I get sent to patients, usually because they have some other traditional risk factor for heart disease. So the combination of the rheumatologic condition plus a traditional risk factor elevates it enough that typically the rheumatologists want me to weigh in on ways to improve that risk profile.
Nice. Mayo Clinic heart specialist, director of the Cardio-Rheumatology Clinic, Dr. Rekha Mankad. Cardiovascular diseases are indeed women's greatest health threat, and more women in America are realizing that.
And if you suffer from rheumatologic disease, you are at an increased risk for heart disease. Thanks for joining us to talk about both topics today.
Thank you very much.